Thank you so much, Dr. Syed. And I would like to take this opportunity to thank SGI for giving me the opportunity to be part of the EUS Masterclass. I have no conflicts of interest to declare, and I'll just start off with, before we go into the details of EUS-guided tissue acquisition, I thought we'd just briefly touch upon the history of endosonography and how EUS FNAC came in. In 1980, the ultrasound probes were attached to the endoscope for the first time, and in 1992, the first FNAC was performed by Peter Willman and his colleagues for a pancreatic head lesion. In 2 years' time, we realized the importance of having rows. And from 1994, there had been a rapid progression, and different lesions and different sites were targeted for EUS-guided FNAC. But towards the turn of century, we realized that we needed more core tissue, and FNAC was probably not enough. And then came the development of core biopsy needles. And in 2011 came the ProCore needle, 2016 fork type of needle, 2017 the Francine type of needle. And by 2018 and 19, we realized we do not need rows probably anymore, and rows gave way to MOS, or macroscopic on-site evaluation. This is the prototype needle that was used by Peter Willman for his FNAC. And as you can see, over a period of time, there has been a generational change in the EUS FNA needles. FNA needles are still available from 19 gauge to 25 gauge. The FNB needles have moved from first generation, second generation to currently the third generation FNB needles. What is available is the Shark Core, Acquire, and the ProCore type. Now, before we go into the details of EUS-guided tissue acquisition, let's look into the type of cases we usually get for a referral for an EUS-guided FNA. Most of the common lesions that we get in our country are lesions in the pancreas, which can be solid pancreatic masses, and cystic pancreatic lesions. The cystic pancreatic lesions, which are usually the target for FNA, are cysts which are more than 1.5 centimeters, have a solid component within, or have an associated dilated duct. Lymph nodes in the periintestinal and mediastinal locations. A common indication for EUS per se is subepithelial lesions. EUS-guided tissue acquisition is probably helpful only if the lesion is more than 2 centimeters, if there's a GIST which is under consideration for targeted chemotherapy, or if there's a suspicion for cancer, lymphoma, or metastasis. The other indication is, of course, gut wall thickening, and if biopsy is inconclusive, EUS-guided tissue acquisition is particularly helpful. Bile duct strictures involving distal and mid-CVD is EUS-guided tissue acquisition has a very good sensitivity and specificity. Hilar cholangiocarcinomas is one area we tend to avoid EUS-guided FNA if the patient is a candidate for transplantation. However, in those patients who are not candidates for transplantation, EUS-guided tissue acquisition is a good alternative. Now, what are the contraindications for EUS-guided FNA? The contraindications include patients who cannot tolerate sedation or general anesthesia, patients who have coagulopathy, either platelet count less than 50,000 or an INR more than 1.5, patient on anticoagulant medications, or patients who are hemodynamically unstable. Now, once we have got our indications correct, we have ticked the contraindications away, then we start off with the procedure per se. The procedure starts off with visualization of the target tissue. And once you have adequately visualized the target tissue, what we generally recommend is to enlarge the target tissue as much as practical. This will help us not only to visualize the target tissue properly, but also helps us identify adjacent organs like a duct or a vessel which can be lying in the near vicinity of our target. An undrained duct, if punctured, carries the risk of cholangitis, and we do not usually would like to puncture a blood vessel. Use of H-flow or power Doppler helps us identifying small vessels which can be lying anywhere within the needle path. Now, next is to position the scope. Now, ideally, the scope should be positioned in such a manner that the lesion lies within the natural path of the needle. The needle usually comes out in this angle, and the scope should be positioned such that the lesion lies somewhere to the center and to the left of the screen. The EUS probe can then at this position be used to apply a gentle pressure on the lesion as much as possible with an up-down button of the up-down dial of the scope so as to immobilize the lesion and facilitate subsequent puncture. Now, this is a schematic diagram of a EUS needle. Most of the EUS needles currently available have the same standard construct. It usually consists of a handle, a shaft, and an adjustable slider for modifying the sheath length. On the shaft, there is a stopping device which regulates the length of the needle. On the adjustable slider, there's another stopping device which regulates the length of the sheath. Sheath is what covers the needle and protects the scope as the needle is passed through the echoendoscope. Within the needle lies the stylet. Supplied along with the needle, mostly you get a vacuum syringe, which can be used for suction. Now, once we have identified the lesion, now we are ready for the puncture. We take out the needle from the cover, and what we usually do in our center is to request the technician to lock the needle at a 0 position. What I mean by that is to put the stopping device on the shaft at 0 position. This will prevent the needle from protruding beyond the sheath and thereby prevents the scope damage. The next step is, of course, to pass the needle into the channel. Now, this may sound easy, but can be sometimes very, very challenging. And movement can be made easier if the scope is not bent either by the elevator or a bent scope. And a bent scope is occasionally encountered when the scope is positioned in the duodenum. If this needle is not coming out, best is to pull the scope back into the stomach and sometimes even into the esophagus to straighten the scope and push the needle in. If still the needle does not come out freely, do not push. Now, needle is out. We have got the needle out and we have fixed it in position. The next step is to take out the sheath. The sheath should be kept out as little as possible, only by a 3 to 5 millimeters. We do not want to keep a long sheath outside because the longer the sheath is, it decreases the length of movement. A shorter sheath allows for a wider length, a wider angle of movement of the needle, thereby sampling a larger area of the target tissue. Now, this is a step which I usually recommend for most of the beginners of EUS, may not be applicable for experienced endosonographers, and that is to mark the length from the sheath to the maximum extent of the lesion. Now, this we do so as to prevent the needle from overshooting the margins of the target tissue. Once we have got this length, we use this length to fix the stopper of the needle at the measured length. And thereby, this prevents the needle from overshooting its margins. This being done, we have identified this. We draw the stylet by a few millimeters to expose the sharp edge of the needle. This is one aspect of needle called the needle handling of the needle. This is what I usually teach my students and the trainees who come to us, is how to handle the needle. The fixed component of the needle can be grasped between the palm and the last 2 or 3 fingers of the right hand, and the movable portion of the needle is usually grasped between the thumb and the index finger. This allows for a free movement of the needle, and the puncture can be done with a single motion of our 2 fingers. Now, the most important step is to move the needle into the target tissue. Now, this is a technique called the fanning technique, where different areas of the target tissue is sampled while keeping the needle within the target tissue itself. As you can see, the needle is being passed into different areas smoothly and easily into different areas. Now, this movement can be facilitated by use of the elevator, and if the elevator does not help, even the up-down button of the scope can help to move this needle. Now, this is helpful when the lesion is soft, mobile, but sometimes we do encounter very hard lesion, like in a pancreatic cancer, where there can be intense desmoplastic reaction, and in fact, doing the first puncture itself can be very daunting. Here in this case, what we can do is something called a multi-pass technique. In the multi-pass technique, we select one area, make multiple passes, at least 3 or 4 passes in that particular area, as you can see here. 3 or 4 passes is made in that area. Once complete, needle is pulled out completely out of the lesion, and again, a different area is punctured. 3 or 4 passes are made into that area. And then again, the needle is pulled out and a different area is targeted. Thereby, in this manner, in the same pass, different areas of the target tissue is sampled using a multi-pass technique. For a cystic lesion, the strategy involves using a larger gauge needle to aspirate most of the contents of the cyst. When there are more than one cyst, the larger of the 2 cysts is usually a target for aspiration. And FNA is usually performed if you find a thickened septa or a mural nodule. This can be used as a target for doing an FNA. But sometimes in cystic lesion, as in this case, where you may not find a clearly cystic content within and has a bit of solid content within, you can use, in fact, a smaller gauge needle like a 22 gauge needle for doing an FNA. And in this case, we had a solid pseudopapillary tumor. So what is the right needle for us? And this is has been extensively studied, at least for pancreatic neoplasm. 7 randomized control trials. A meta-analysis of the 7 randomized control trials actually showed there was no difference as regards sensitivity, specificity, and adequacy was concerned. A subsequent meta-analysis done in 2017, which included 4 additional non-randomized prospective studies, showed that the 25 gauge needle had a higher sensitivity when compared to a 22 gauge needle. For me, this is what I would prefer. For a pancreatic solid mass, I usually prefer to use a 22 gauge needle. I use a 25 gauge needle for lesions in the uncinate. For pancreatic cystic lesions, I prefer a 19 gauge needle. Where core tissues required, I use a 22 gauge or a 20 gauge FNB needle. For lymph nodes, I prefer a 22 gauge needle. And for a repeat FNA, I usually prefer to use a core biopsy needle. Now, another area which is a matter of concern, this has come in and gone out, is called a question of suction, whether we need to use suction. Studies have shown that suction actually increases your diagnostic accuracy, cellularity. However, it does come in with the limitation of increasing the bloodiness of the sample, and pathologists are not particularly happy when they get a very bloody sample. So suction went on from doing dry suction to slow pull technique. The slow pull technique is nothing but just pulling the stylet out gently while the needle is used to make to and fro movement into the tumor tissue. By pulling the needle out, by pulling the stylet out gently, what we create is a negative pressure within the needle itself. Now, slow pull technique, has been compared to suction and dry suction, and multiple randomized control trials have been done, and overall meta-analysis of these trials show that the adequacy is comparable between slow pull and suction. Accuracy is comparable. However, the degree of blood contamination is more with suction than the slow pull technique. Another way to perform suction is called the wet suction. In wet suction, 5 ml of saline is injected into the needle, and then the suction syringe is connected. And with this assembly in position, the FNA is performed. Once the needle is into the tissue, the FNA is the suction is activated, and FNA to and fro motions of the needle is done within the tumor tissue. Systematic review of wet suction versus dry suction techniques have shown that the sample adequacy is probably higher with wet suction. However, the degree of blood contamination and the rates of histological diagnosis are comparable. So do we do anything different when we are doing FNB? At least I don't do anything different. I perform the FNB in the same manner as I would do an FNA, or I do this. This is in a case with a subepithelial lesion with a suspicion for GIST, which was referred for an FNB. And here you can see I use the same fanning technique to do the FNB. Multiple areas of the tumor tissue is sampled in the same pass. Only thing different here is that the number of passes required to obtain a tissue diagnosis is probably less. This is again another case of where FNB was done for a patient with a suspected pancreatic neoplasm, where the initial FNA was negative. The tissue had a very, you can see on elastography, had a blue color, suggesting there's a very hard tissue. FNB was done using a 22 gauge needle, and you can see here at macroscopic examination, a good amount of tissue was available, and histological examination confirmed the diagnosis of adenocarcinoma. Occasionally, despite everything, we do encounter difficult scenarios where the scope positioning itself is difficult. This particular case, as you can see, a metal stent had been placed for a suspected extrahepatic biliary obstruction elsewhere, and the patient was referred for chemotherapy, and the tissue was required for starting chemotherapy. And where we would like to place the lesion between center and slightly to the left, it was difficult because the stent was restricting the mobility of the lesion and the scope. In these circumstances, what can we do is to best optimize the position of the needle as best as we can and get as much of the tissue as we can using either our up and down button, the wheels, and sometimes the help of an assistant to hold the scope. In this case, we were lucky enough to get tissue diagnosis and confirm the diagnosis of adenocarcinoma. Similarly, in another situation where we can encounter difficulty is in small mobile lesions. In small mobile lesions, we use a technique called a quick puncture. What we do is we press the lesion with an EUS probe as close as possible, trying to fix it. The needle is advanced further just above the lesion, and we time the puncture in coordination with the respiratory movements. And this puncture is done as a single quick stroke. Once within the lesion, the sampling is completed using the fanning technique. The different difficult scenarios that we can encounter is what I described earlier: unstable scope position. Best optimized may use an assistant to hold the scope. It's a difficult position. Use as much as possible. Use your up-down button. Use your wheels. You use the scope positioning. May require an assistant. For mobile lesions, fix the scope with a probe and do a quick puncture. For small lesions, I suggest we fix the needle distance first and then proceed with a quick puncture so that we don't overshoot the lesion. For hard lesions, again, a quick puncture is helpful, but I would prefer to use a core biopsy needle. In hypervascular lesion, especially neuroendocrine tumors, use Doppler, avoid areas of increased vascularity. If that is not possible, definitely use only a 25 gauge FNAC needles and avoid FNAB. So, ladies and gentlemen, EUS guided tissue acquisition is a safe and a sensitive tool for tissue acquisition. The technique of tissue acquisition can be learned easily, and these principles can then be applied to other EUS guided therapeutic procedures. However, care should be exercised in selecting the right patients and in handling the EUS scope and needle. Thank you for your patient hearing.